The drawbacks of the current prediction tools for pneumonia, there's a few. So a lot of them really are dependent on the patient population they're studied in, how the studies defined their patients as having pneumonia. Some of the initial studies were based on administrative level data of only patients with positive bacterial cultures from the respiratory tract. And so those patients were actually very different than what we actually see in the hospital, because most patients we don't actually identify a pathogen ever. Many patients are viral, have viral causes of pneumonia in origin. So a lot of those patients, we don't need to be using broad spectrum antibiotics, or in the case of primary viral pneumonia, any antibiotics whatsoever. So these studies are very sensitive to how they're designed, how they're defining pneumonia, and then their own local epidemiology. Certainly there's greater resistance in certain areas of the country, or in certain centers, or depending on where the patients are coming from. If they have a feeder population from a nursing facility that has a lot of resistance, that can cause a lot more baseline resistance in pneumonia to start. And so what we really need is we need local data. Each institution needs to have their own information about how prevalent is multi-drug resistance in pneumonia to start, and then what are our own risk factors. So there's a lot of studies looking at this, and a couple of themes do keep coming up. Previous antibiotic use is often a risk factor for multi-drug resistance in pneumonia. Previous healthcare exposure is often a risk factor as well.